Welcome everyone to the Leukemia and Lymphoma Society of Canada's training called Optimizing Sexual Health and Intimacy After a Cancer Diagnosis, Part 1. This training is geared towards the healthcare professionals in our community. In this part, Reanne Booker will review the concept of sexuality in the context of cancer and the potential impact of cancer and its treatment on sexual health and intimacy. First, I'm going to introduce myself. My name is Natasha Sani, and I'm the Community Services Lead for the BC region. So before we begin our main presentation, I would like to share with you our mission and highlight some of our resources that might be helpful for you and your patients. At the LLSC, our mission is to cure blood cancers and improve the quality of life for those touched by blood cancer and their families. Ultimately, we're here to serve the community. We offer guidance and support to people affected by blood cancer every step of the way. We offer a continuing education program that you can join freely. Last year, we sent a survey to hematology oncology healthcare professionals around the country, identified a need for training on blood cancers. You can register to one or more of our trainings, and you can complete them at your own pace, and you receive an electronic proof of participation. Our educational tools are offered in a variety of formats, from podcasts, animated videos, fact sheets, and more. And these are aimed at different types of audiences. For example, these fact sheets here are on communicating your health with your healthcare team, fertility, and for caregivers. Support your loved one following a cancer diagnosis. All of our materials can be downloaded or ordered through our website. The process is super simple. This handy electronic form, you can order materials to be shipped directly to your location. It just takes a few clicks. If you need any help, please reach out to your community service lead in your region. I also like to highlight our LLSC Health Manager app. This is a free resource and is also available in French and in English. This app helps patients track side effects, medication administration, food, and offers a hydration journal. The app also offers medication reminders and has a nutritional meal planner along with many recipes to help patients get the nutrition they need. The app also allows access for a caregiver and is free to download in the App Store on Apple or Android devices. Emotional and practical support is important for the LLSC. Our peer support program has been identified as a key service, but many do not know about it. Volunteer survivors who are at least 1 year out of treatment are selected and trained, and they share their stories with newly diagnosed patients or those may be facing a new treatment option. Age, gender, diagnosis, and treatment are all considered to ensure that we offer the best possible match. This program helps build hope. It alleviates anxiety, and it creates realistic expectations. We also offer a virtual support group from coast to coast, and these are professionally facilitated. Our support group gives the opportunity for blood cancer community to connect with others who are facing similar challenges from the comfort of their own home. Each participant builds connection through group discussions, sharing coping methods, and information sharing, as well as breaking isolation. Visit our website, www.bloodcancers.ca, for more details. It is now time to introduce you to our speaker, Reanne Booker. Reanne is an oncology and palliative care nurse practitioner with over 20 years experience in nursing. She works with the palliative and end-of-life care services program in Calgary, Alberta, and she's a PhD candidate at the School of Nursing with the University of Victoria. Her clinical and research interests include the integration of palliative care and oncology, sexual health and cancer, advanced care planning, medical assistance in dying, cannabis and cancer, global oncology, and health equity. Over to you, Reanne.
Well, thank you so much for the introduction, and thank you so much for the invitation. And thanks to everyone who's viewing this video. I think that this is such an important topic in the care that we provide, and one that is often overlooked in cancer care. So here's my conflict of interest disclosure. I haven't received any funding or I don't have any financial relationships with industry at all. I have received some funding for my PhD studies through nonprofit organizations and governmental organizations, but nothing from industry. And the objectives for part one of this talk are to review the concept of sexuality in the context of cancer, and to talk about the potential impact of cancer and its treatment on sexual health and intimacy. There is a part two of this series, and that second part of the talk will address management and interventions pertaining to sexual health and intimacy. So just to remind everyone that sexuality is a central aspect of being human throughout life. And it's not just sexual function, but really all those dimensions and beliefs, attitudes, values, behaviors, and such. So very often when we think about sexuality, I think sometimes we narrow it down to sexual function. But just to make the point that sexuality is a much broader concept. I will speak about sexual function quite a bit throughout this talk, but just to keep in mind that sexuality is a broader concept. And when I first started working in cancer care many, many years ago, I worked in a genitourinary oncology clinic where we often asked about sexual health and concerns that patients had. And I found that when I asked those same questions in the hematology cancer clinics that I was working in as well, the patients with blood cancers also had those similar concerns that the patients in the other clinics were reporting. And it was quite enlightening to me because I think we just assumed, that the patients with prostate cancer or testicular or penile, or even in the female side of things, when we think of breast cancers and such, it might seem more intuitive that sexual health concerns are more common in those types of cancers. But in actuality, sexual health concerns are very common, irrespective of the type of diagnosis. And so this is a diagram that, as I was starting to do the work in sexual health and cancer, it really became apparent that there were so many different factors that can influence sexuality and sexual function. So certainly things that a patient comes into a cancer diagnosis with, so their history, any other medical conditions or comorbid medical conditions that they might have, culture, religion, previous experiences, partner and spouse, and then certainly things that the cancer brings to the equation. So the cancer itself can have a direct impact on sexual health and intimacy, and then the treatment and the associated symptoms, side effects, the psychosocial piece as well. As I mentioned earlier, we know that sexuality is a broad concept encompassing aspects of self-image, body image, patterns of affection, social, family, gender roles, as well as physical and emotional intimacy. And that, again, these factors that influence sexuality can precede a cancer diagnosis. They might arise upon being diagnosed with cancer, or they might emerge with treatment. Some of the factors are associated with normal aging, and others might be exclusively related to the cancer and its treatment. And very often there's overlap between the two. We know that sexual function relies on intact nervous, vascular, and endocrine system function. And it's not just those body system functions that we think about, but the brain also is one of the most important sex organs. And certainly we know that there can be an array of psychological factors that can contribute to altered sexual function and sexuality. Things like body image, self-esteem, altered mood, depression, anxiety, gender role confusion, and fear. And again, many of these can be impacted by cancer and the treatment. When we think about sexuality across the illness trajectory, so at time of diagnosis, it might not seem like it's very important. And certainly in some of the qualitative work that we've done, we've heard patients tell us, at time of diagnosis, when the focus is very much on trying to learn everything they can about the diagnosis and the impact on survival, especially, it may not seem like the most important time to bring up sexual health. But there can be important factors here for sure. So if patients are thinking about fertility preservation, this is a critical time to bring up fertility preservation before we even embark on any treatments for the cancer. And then again, during treatment, intuitively, it might seem that people might not be that concerned with addressing sexual health concerns during treatment. Getting through the treatment, managing side effects and such might seem to be the priority. But there are patients who still desire that physical intimacy and closeness during treatment. And there can be some safety concerns in terms of partner exposure to chemo and things like that, which I'll get into a little bit more later on. In our clinic, we most often saw, so at our cancer center, we had a sexual health clinic that ran for a number of years until our funding ran out, unfortunately. But very often we did see patients during that follow-up recovery and survivorship phase. So once the primary disease-directed treatment had finished, we then saw patients come to our clinic with these concerns. And I think for a lot of patients that makes good sense, and certainly for the treating teams, it probably makes sense. But there are some reasons to begin the assessment and management of sexual health concerns earlier on, even things like vulvovaginal changes. If we can catch that fairly early on after the concerns have begun, we have a better chance of managing that concern, and certainly easing the distress associated with those concerns if we can catch it early. And then again, during advanced disease and at end of life, it might be a time when people think that that's not a time when people maybe desire sexual intimacy, but certainly we've heard that from patients. And it may not be sexual intercourse or that physical intimacy part, but they may still desire the emotional intimacy and closeness. And so helping patients with that aspect can be very important, even at end of life. I was asked a couple of years ago to go give a talk at one of the hospices in the Calgary area, and their staff had walked in on a couple, and they were quite shocked that the patient and the partner were engaging in physical intimacy. And so they asked me to come give a talk, and they joked a little bit about how should we let staff know if there's something going on in the room. Should we put socks on the doors or have a sign or something like that? But it really brought to light the fact that human beings really do desire that closeness, even at end of life. That can be very, very important for some patients and couples. There are many assumptions and myths associated with sexual health, and this is even beyond the cancer context. So the patient is too old to be having sex, and we saw people in our clinic of all ages, and I even taught an older gentleman, I believe he was in his early 80s, how to do penile self-injections for erectile concerns after prostate cancer treatment. The patient is too sick to be having sex, and that very well may be the case for some patients, but I think we ought not to assume that that's the case. And certainly sexual function and sexual intimacy may still be a priority for a lot of patients, even if they're feeling unwell. The patient's not thinking about sex at a time like this. Well, you know, the only way we know is to ask the patient if it's a concern or not. And I'll tell you from my own experience in asking patients, if it's not a concern, they'll simply tell me or tell you, no, it's not a concern. I'm not worried about this at this point in time. And then if there's a problem with sexuality or sexual function, the patient will bring it up. We know from the literature that this is just not the case. Patients really will wait for us to bring up this topic. If we don't bring it up, then they will just assume it's not important. They might think there's something wrong with them if we're not assessing this or addressing this topic. And at our cancer center, we have a little checkoff form, and sexual health concerns is one of the topics that's on the form. And in our qualitative work, I heard from a number of patients that they said they did check off that sexual health was a concern, but nobody ever brought it up. And one patient in particular said he thought that people must have just assumed he was joking about it, and therefore it was not addressed at all. So I think it's great that we include these things on our patient-reported outcome measures, but the next step is really to make sure that if patients are reporting concerns, then we do something about it. And this is just a paper to show that sexual activity indeed is associated with greater enjoyment of life in older adults. So that number one assumption there, the patient's too old to be having sex, I think we really need to check our own biases and assumptions there. So in terms of what can be impacted after a cancer diagnosis, so you can see from this busy slide, there are lots of different aspects of sexuality that can be impacted by cancer and its treatment. And certainly very commonly, we would see decreased interest and desire in sexual activity, vulvovaginal atrophy, vaginal dryness, difficulties with orgasmic function, painful intercourse, again, sometimes relating to the very dry vaginal tissues, ovarian failure, which could be permanent or temporary, and very often after the treatments that we utilize for blood cancers, in particular for doing things like allogeneic hematopoietic stem cell transplantation, we can see permanent ovarian failure, even in very young women, which can be particularly distressing. Again, there can be disease and treatment specific impacts. So again, after allogeneic transplant, we can see vaginal graft versus host disease. There can be surgery specific concerns as well. Altered fertility, which could be an entirely separate talk, can also be impacted with cancer and its treatment. And then a whole array of psychosocial concerns, as I've already mentioned, to body image, self-esteem, depression, anxiety, relationship difficulties. And we know that the various different modalities of treatment can have varying degrees of impact on sexual function. Some of the newer agents, the immuno-oncology agents, we don't yet know, and things like CAR T-cell treatment, we're just starting to realize what the side effect profiles and longer term sequelae will be after these therapies. I would say in our clinic, the most common concerns that we would see really, and it was irrespective of the type of cancer or treatment, were really vulvovaginal changes, as well as decreased interest and desire and painful intercourse, which you can see, I'll show you in a bit, how they're all kind of interrelated. Certainly we see, and this will happen to women or females, even in the absence of a cancer diagnosis, that after menopause, once estrogen is becoming more diminished in the body, we can see significant changes in the vulvovaginal tissues in particular. And so we can see things like genital dryness, decreased lubrication and with sexual activity. That can lead to painful sexual activity. There can be bleeding. You can imagine if intercourse is painful, that can certainly impact desire and interest in sexual activity and even orgasm. We can see things like urinary symptoms. When we do physical exams, we can certainly see changes in the vulvovaginal tissues as well. Labia minora resorption and alterations in the vulvovaginal architecture can happen after loss of estrogen or premature ovarian failure, and that abrupt treatment-induced menopause that we sometimes see with different types of treatment. And for males, we saw a number of changes as well. So certainly, again, we would see decreased interest in desire and sexual activity, arousal difficulties with challenges with erections, and that might manifest as difficulty achieving or maintaining erections, difficulty with the firmness of erections, changes with ejaculation and orgasm. Again, for males, there can be altered fertility. For many men, that tends to be a temporary or transient, but it can be permanent for some. And then again, males also experience an array of psychosocial challenges after a cancer diagnosis and treatment. And like the females, we will see that the various different modalities of treatment can impact sexual function and sexuality in varying degrees. I would say in our clinic, the most common concerns that we saw with the male patients were erectile changes and also decreased interest and desire. So again, changes in desire, very common, and that can really happen with any type of cancer treatment, chemotherapy, total body irradiation, but certainly can also happen as we age. And this notion used to be this kind of linear process, the sexual response cycle that many people are aware of, that was first kind of described by Masters and Johnson in the 70s, where there was this kind of linear process where desire would first kind of happen, and then that'd be followed by arousal, excitement, and then orgasm. We know in real life that doesn't always proceed in a linear fashion. So certainly we know that people may not be in the mood or may not have that spontaneous sexual desire, and they can go on to have a very satisfying and pleasurable sexual experience. So it need not proceed in this linear fashion. And this becomes important because as the hormones change in the body from aging or treatment, there may not be that spontaneous sexual drive. And so some people think, well, if that spontaneous sexual drive isn't there, the rest of that cycle can't proceed. And what's the point in even trying? And we certainly know that through counseling and discussion and awareness, that people can go on to have very enjoyable sexual experiences, even in the absence of that spontaneous sexual drive. So somebody might say, I'm not really in the mood, but maybe their partner comes over and starts gently massaging their back. And then maybe the desire comes afterwards. And so it doesn't have to proceed in that linear fashion. There are all kinds of different ways that sexual response cycle can proceed. So changes in erectile function, as I mentioned, there can be difficulty with achieving erections, difficulty maintaining erections, insufficient firmness for penetrative intercourse, and that could be vaginal or anal intercourse. And for anal intercourse, you need approximately a 30% more firm erection compared to vaginal intercourse. And there can be loss of spontaneous erections and loss of those nighttime or early morning erections. And we know that changes with erectile function can happen with aging, and more than 50% of men over the age of 40 will have some degree of erectile challenges. We also know that there can be a number of different medical conditions and medications that can impact erectile function. The good news is, and I like to really emphasize this, especially when we're dealing with, this is very common in the prostate cancer population, where we do see significant impact of treatment on erectile function. Men do not need an erection to have orgasm. So that's also something that a lot of people aren't aware of necessarily, and that awareness can really help. And we know that, again, as I mentioned earlier, if there's nerve damage, if there's damage to the blood vessels, if there's changes in the hormones, or even if there's a psychological impact of cancer and its treatment, or even something preceding the cancer diagnosis, all of these can have an impact on erectile function. And very often it's a combination of some or all of the above. In the context of treatment for blood cancers, we know that certain types of chemotherapy can damage blood vessels. We certainly know that there can be nerve damage. Total body irradiation can impact hormone function for men and women significantly. So many of the types of treatments that we use in the management of blood cancers can have an impact on erectile function. Changes in ejaculation, we can see, again, because of nerve damage, there can be delayed or premature ejaculation. Less commonly, but we can sometimes see pain with ejaculation, dysejaculation, and that can sometimes be after radiation, where there's damage or irritation of the epididymis, and there's an epididymitis or urethritis that can cause pain with ejaculation. Little or no ejaculate. We don't see this as much in the blood cancer population, but this would be more commonly seen after treatment for prostate cancer. Similarly, retrograde ejaculation can happen after certain types of treatment for prostate cancer and testicular cancer. We're not seeing that as much in the blood cancer population. And climacturia, where there's urine leakage at time of ejaculation. Just to explain what retrograde ejaculation is, that would be where the ejaculate is not expelled out through the urethra or the penis, but rather goes retrograde or backwards into the bladder. And that can happen because of damage to, there's a little, the closure of the bladder neck mechanism that can happen after a TURP for enlarged prostate, or can happen after retroperitoneal lymph node dissection for testicular cancer. So not something we'd expect to see necessarily in the blood cancer patient population. And changes in orgasm for men and women. This was something that we saw quite often in our clinic. And, we would see most commonly, I would say, decreased intensity or loss of orgasmic sensation. Very infrequently, we could see increased intensity. And again, a lot of this has to do with nerve damage or nerve dysfunction. Similarly, painful orgasm or dysorgasmia can happen for a variety of different reasons, and loss of orgasm. And I would say, you can imagine that if sex is painful, or if patients are fearful of sexual activity because of pain or other concerns, that can really adversely impact orgasmic function. So we were very fortunate in our clinic. We had a psychologist that worked in the clinic And very often we would do different mindfulness type strategies to help improve some of these psychological concerns with that we would see that came up after cancer treatment. Body image, again, very, very common for men and women. So we can expect to see sometimes, depending on the type of treatment, weight loss, weight gain. So very common in the blood cancer population. You know, prednisone's horrible for causing weight gain, and especially in the face, there can be that kind of Cushing weight appearance. Hair loss, certainly scarring. You know, after treatment, stem cell transplantation, you can sometimes see different kinds of rashes and scarring and permanent changes in the skin. Not so common in the blood cancer population, but in other types of cancer, loss of body parts and surgeries and things like that. And I would say that this is something that was fairly eye-opening to me early on when I started to do this work in sexual health, is that body image concerns are very common for men just as much as they are for women. In our qualitative study where we interviewed patients after a stem cell transplant, all of the men in the study reported changes with body image that were distressing or significant to them. And here's a quote from our study. It was a gentleman who had a transplant, an allo transplant. And he said, "I remember the first time I looked in the mirror when I got up to go to the bathroom, and I literally fell to my knees sobbing because I didn't recognize the person that I saw. I'm trying to fight tears off now talking about it. I've mourned the loss of who I was. I was stronger physically. Now I might say 90% of what I used to be. I've got a much bigger heart. Some say it's the girl blood that makes me cry so easily." And so this particular patient had a transplant from a female donor, and he used to joke about the girl blood. But his body image was very important to him. He was separated and he was just starting to get back into dating. And he'd previously had a very full head of luscious hair and, you know, had quite a bit more weight on him. And then after transplant was quite frail and thin and had lost a lot of his hair. And it was a very profound aspect of his treatment for him, this body image piece. As I mentioned, fertility could really represent or make up a whole entirely separate talk. I just like to make the point that as much as we can, we should talk to patients prior to treatment. That's difficult in the context of blood cancer because very often, once that diagnosis is made, we need to start treatment urgently or imminently. It certainly is the case with acute leukemias. We don't have the luxury of waiting 6 to 8 weeks to pursue a cycle of in vitro fertilization, for example. We also, for things like in vitro fertilization or egg harvests, ideally you want the platelet count to be greater than 50. So that's not always realistic in the context of acute leukemias. And again, ideally, when I first started working at the Cancer Center here in Calgary, I was fortunate that we have a very good fertility program here in Calgary. I was able to set up kind of a very urgent referral process to the fertility clinic where they would see our patients either same day or next day if they could, as much as was feasible. So they recognized that we, you know, had a very narrow window of time where we could get our patients in to be pursuing fertility preservation strategies. So this could be an entirely separate talk. I don't have time today to get into this, but just to make the point that as much as possible, we like to bring this up to patients prior to starting treatment where it's possible, where it's feasible and safe. There are fertility preservation guidelines that ASCO's put out. And then there are a couple of organizations in Canada that can help with fertility preservation costs. So what is covered in terms of the costs for fertility preservation strategies varies significantly from province to province. And I will say can be a tremendous financial hardship for some patients. So these different organizations here, Generations of Hope and Fertile Future, do provide some financial support. And I know of a couple in Calgary that did receive support from Generations of Hope, and they did go on to have a child, which was very heartwarming and really incredible for them. So relationship changes, again, we know this is a significant concern for a lot of our patients. It can be challenging for existing relationships. So especially, and we saw this in our clinic, If if the couple, if they're not used to talking about sexual health or intimacy, and then there's this major change that's been induced by treatment or the diagnosis, that's something very different. And it can be very jarring and very challenging for an existing relationship. Starting new relationships and getting out into the dating field and figuring out, when do I disclose this history of cancer? And again, in that qualitative study that we did, one of the participants shared that he found it very difficult to date. He knew that there was always kind of this risk of his cancer coming back. And he also said he felt almost, he said it wasn't that he felt like damaged goods necessarily, but there was that looming thought of what he'd been through and what he might face going forward should the cancer recur. And he didn't really want to think about putting a partner through that. So very challenging for relationships. Again, in our clinic, we are fortunate to have the psychologists that could do a lot of couples counseling and help couples with this. But this can certainly be a difficult aspect for sure for many people. Unfortunately, we know that there's not a lot of literature or research on the partner experience, but what we do know from the existing literature is that patients or partners might feel fearful of causing pain or discomfort during sexual activity. So that might cause them or lead them to pull away entirely from pursuing any physically intimate relations with their partner. They might feel unwanted or unattractive or even rejected because there's this decrease in sexual activity in the relationship. They might not realize it's related to treatment at all, so they might take it very personally. Again, too, when they have to shift from being just the partner to being the caregiver all of a sudden, that can really change how they feel and how they see their partner from a sexual perspective or intimate perspective. And so again, if we can provide as much support as possible to patients and their partners so that the partner doesn't always have to take on so much of that caregiving role, that can be very helpful. And then again, too, if there's, this threat or this worry that they might lose their partner, some partners might pull back just to protect themselves. I think, again, we know that partners can have their own sexual health concerns, and so a lot of this will happen as we age normally. And so we found in our clinic, sometimes we might fix the sexual health concern of the patient, but then the partner had a significant sexual health concern. And then we ended up with a discordance in terms of what they were able to do functionally and what they desired. And so again, we are very lucky in our clinic to be able to work with couples as much as the patient and partner wanted that. It was a lot about education and providing information and that kind of thing, rather than a lot of interventions for the partner, but more so the provision of information and education that they could then take back to their family doctors. We don't have a lot of research or literature on the experience of sexual and gender minorities, but we know that approximately 10 to 12% of the population identifies as LGBTQ. And in that particular patient population, we know that there's lower rates of early detection, lack of access to screening, and lack of resources tailored to their needs. So, this one survey of oncologists that was done a few years back, a lot of the oncologists said, well, I treat all my patients equally. And that might sound good on the surface, but the goal in healthcare really is for equity, not equality. And I can use the example that, we may have a patient who's got a significant visual impairment or vision impairment. And if we just said, well, we're going to treat you equally, we're just going to give you the same handouts that we give all of our other patients, that's not meeting that patient's needs. They're not having equitable care because they can't read the handout we're giving them. So we really need to think about what the unique needs are of our patients and then really strive to meet those unique needs. So again, really trying to think about being trans inclusive and really trying to, a lot of what we do in healthcare is not very sensitive to patients' needs in terms of their privacy, and certainly when it comes to their identity, we're not always very sensitive. So this table This came out just, I believe, in 2021, there it is, to talk about things that we can do in our clinics to make them more trans inclusive and to make patients feel more comfortable. And again, just for people who aren't aware of the terminology, to be aware of some of the terms. What does it mean to be transgender? What does it mean to be cisgender? And the various different terms that can be very relevant. And, sometimes I've made mistakes and I've, I always try to be inclusive and sensitive and aware of patients' preferences in terms of their pronouns and who they identify as their partner and their chosen family. I've not always gotten that right. And I'm okay and humble enough to say and to apologize and say, I'm really sorry, I messed up here. And, but I, really trying to make sure that we're inquiring and then honoring patients' preferences. And that's not unique only to gender and sexual identity, but certainly across the board in terms of other needs that our patients have as well. We know that there can be significant challenges experienced by adolescents and young adults with cancer. And I think, this is very relevant for the blood cancer population as well, because we do see a lot of younger adults and even adolescents and younger children diagnosed with blood cancers. And this was a survey that was done a few years back by the Canadian Partnership Against Cancer and 10 provincial cancer agencies. And they surveyed 575 adolescents and young adults with cancer. And this was between 1 and 3 years after treatment had ended. And you can see that 41% of this population reported concerns with sexual activity or function, and 62% didn't seek help for their concerns. Nearly half thought that there was nothing that could be done about it anyway. So that was part of the reason why they didn't ask for help. And then of those that did ask for help, 40% of them had difficulties getting help. Similarly, the emotional challenges experienced by this patient population. So nearly half, again, reported changes in their sexual intimacy. 75% did not seek help. Again, some were even told that it was normal to expect this. Some didn't want to ask. So here again is that misperception that patients will bring it up. We know that that's not always the case. And then again, almost half had difficulty getting help when they did bring up the concern. So this really emphasizes that we have more work to do and we need to be better about supporting our patients with these concerns. Again, in this special population as well, at advanced disease and end of life, this is one study where 65 patients were randomly selected and provided a questionnaire. This was an Italian study. 86% thought that it was important to talk about sexuality. And then before diagnosis, more than half reported a good frequency, and good frequency was defined as sexual activity once per week, I believe. And then after diagnosis, only 3% reported good frequency, and 3/4 reported insufficient or no sexual satisfaction at all after the cancer diagnosis. This is a Canadian study done actually in Calgary, and the setting was hospice, palliative home care, or the tertiary palliative care unit. And it's a qualitative study. And what the participants shared was that the sexuality itself was still felt to be a very important part of their quality of life, but how they expressed their sexuality had changed. The meaning of sexuality was not necessarily different, but how they expressed it because of their diagnosis, and in particular at end of life, how they expressed their sexuality was different. There are barriers to experiencing sexuality in institutional care, of course, the lack of privacy, the single tiny hospital beds that we have. Wouldn't it be great if we had double beds? And again, not necessarily for sexual activity, but just so patients and their partners could snuggle or cuddle in bed and be together. And then again, a big barrier was discussing sexuality with healthcare providers. Lots of different considerations, I would say. So certainly if people are having symptoms that are unmanaged, it's bound to be a barrier to sexual intimacy and sexual function. These are things we can help with. And then again, just thinking about that environment. So there can be oxygen and tubing that might get in the way for our blood cancer patients. There can be central lines and things like that that they might be worried about, that they might get pulled on. Hospital beds again are single and not room for two usually in the beds. And we wouldn't permit that in some circumstances anyway, but why wouldn't we? And then the hospital environment being quite uninviting, and then lack of privacy. So it could be double rooms, or it could be multiple patients in one room. Even in hospice, where there tends to be only one patient per room, we're bad as healthcare providers at sometimes just knocking, but then walking in right away. And so finding ways to really honor and maintain privacy for patients can be really important. So just to summarize this first part of the presentation, sexual health concerns after a cancer diagnosis are very common, and they can occur after any type of cancer treatment. They can really have an adverse impact on quality of life and can cause a lot of distress for patients. Healthcare providers very often overlook this important aspect of care. And I would say that nurses are ideally suited to help assess and manage sexual health concerns. As nurses, we very often get to spend a lot of time with our patients. We get to know them very well, and they very often will share things with us that they don't always share necessarily with their physician providers, just because we have that opportunity for that relationship building and the chance to spend a little bit more time with them sometimes than our physician colleagues do. So I'll make the case there that nurses are ideally suited to assess and help manage sexual health concerns. And then I will invite you to please view part 2 of this presentation to learn how you can help with these sexual health concerns. Thanks very much.
Thank you so much, Reanne, for this great training. If you would like to learn more about how to support your patients and caregivers, we have other training available on our continuing education platform. There's the part 2 of this training, optimizing sexual health and intimacy after a cancer diagnosis. Part 2 will address strategies that will help optimize sexual health and intimacy and resources for oncology nurses. We also have 2 units available to support the LGBTQ2+ community offered by Queering Cancer, providing inclusive care for LGBTQ2+ people affected by cancer. Unit 1 is background and terminology, and Unit 2 is about clinical practice. Don't hesitate to visit www.bloodcancercontinuingeducation.ca. And finally, I would like to remind you that we are here for the blood cancer community. We can help those affected by blood cancer to cope with every step along their experience. You can order material to refer your patients and their family to our services easily. Thank you so much, and stay safe.